Hello, everyone. This is Shad Reis from SCAI 2025. I'm very privileged to be with Dr. Katrina Dangas to talk about her late breaker trial. Congratulations, Katrina, for being accepted for late breaker at SCAI.
Thank you so much for having me today.
Yeah. So we talked online a little bit. You talked about PCI and ambulatory center. So tell us about the hypothesis and the idea for this research topic.
Yeah, absolutely. So, over time, over the last 20 years, more and more cardiovascular procedures are moving into ambulatory surgery centers, driven by, technological advancements, as well as the potential for cost savings associated with this setting for payers. And most recently in 2020, following the emergence of evidence supporting the short-term safety, the safety of PCI with same-day discharge and without cardiac surgery on site, Medicare began reimbursing for PCI in ASCs. But nevertheless, since this policy change has happened, the data on ASC PCI has remained exceedingly thin, and we sought to start to close this evidence gap.
Absolutely. So, as you said, this is evolving, and safety has been shown is good and decent in these centers. So, tell us about what is the idea behind it and the main finding.
Yeah, so thank you very much. So our we had a number of main findings. We note, first of all, that the number of PCI and ASCs is increasing, but it still makes up a small proportion of outpatient PCIs, less than 2%.
Wow.
There were some differences in patient characteristics. Patients from ASCs were more likely to be from the South and more likely to be from socially vulnerable regions as compared to the benchmark that we set, which was hospital outpatient departments. There was also less utilization of atherectomy and IVUS in the ASC setting. Now, in terms of the safety outcomes, we did a benchmarking analysis comparing ASCs to hospital outpatient departments, and we found that at 30 days, in terms of our safety outcomes, which included mortality as well as a number of adverse events, they were pretty good in the ASC setting, which supports the short-term safety of PCI in ASCs in selected patients, which is the key bit. However, we would caveat our finding with the fact that, further research is really needed to validate these findings, ideally in prospectively collected databases.
So from your analysis, are these patients usually healthier or they are more sick to go to the ambulatory?
So in terms of the measured characteristics, we did find a few differences. They were broadly similar, but we did find that patients in ASCs were less likely to have had a prior AMI within a year and were more likely to have peripheral vascular disease. However, we hypothesized that there might be a number of unmeasured differences between the populations, particularly pertaining to angiographic risk, which we couldn't ascertain through claims.
Yeah. But at least, as you said, it's 2% of the PCI is done out. It's very low, but again, a good favorable outcome. But my suspicion is maybe there is some selection. Basically, if somebody healthier, less sicker, doesn't need the surgical backup or low EF, maybe been sent to the surgical center.
Yeah, exactly. I mean, SCAI's guidelines stipulate pretty clearly that patients who are to undergo PCI and ASC should really represent the lowest risk patients in terms of both clinical factors as well as anatomical factors. Absolutely. So you're correct in that. And Absolutely. I think further research in national registries that are being established now will really be illuminating.
That's the perfect start now using this database. Congratulations again, Katrina, for being accepted for late breaker at SCAI 2025 in Washington, D.C. Watch these videos and other on SCAI-TV. This is Shad Reis coming to you from SCAI in Washington.